Welcome back. I'm Dr. Glenn Chertow, and now I'm joined by the three presenters you've just seen, Dr. James Kazama of Fukushima Medical University, Dr. Suguru Yamamoto of Nagato University, and Dr. Jeffrey Silversweig of Weill Cornell Medical College. I'm also joined by Dr. Yusuke Tsukamoto, who has been working closely with KDIGO to help facilitate this discussion. Thank you all for joining us today. Now I have a few follow-up questions which will help build on the discussion earlier. Since DRA is uncommon, when do you carry a high index of suspicion, especially in an era where biopsies are not performed?
Since we don't have sufficient biochemical examination to screen DRA, I think the most important thing is to listen to patient's complaint. Then physical examination, then maybe neurophysiological examination.
And what do you look for on physical examination?
Carpal tunnel syndrome is a medial palsy, so like the decrease in pinching power or atrophy in the thumb ball or pains pattern, I mean the flexor pain in joint. That's the important things, I believe.
And others?
Yes, also, so destructive spondylar arthropathy is the main symptom, one of the main symptoms of the DRA. So we can screen the symptom with X-ray or MRI for the spinal. I think this is a screening method for the destructive spondylar arthropathy is one of the DRA symptoms.
And I think in the United States, one of our difficulties is that we don't have good treatments available, so efforts to diagnose DRA are uncommon. But I think that in terms of index of suspicion, it's patients who've been on dialysis for a relatively longer period of time and then begin to complain of pain, carpal tunnel syndrome, and related symptoms.
And are there other clinical or laboratory signs that you look for?
Well, as the gentleman mentioned, imaging is really the primary factor. Certainly blood levels of beta-2 microglobulin would be helpful, but I don't think they're routinely done in the United States, again, because there isn't much we can do about it, because we don't have hemodiafiltration available, and almost all of our patients receive high-flux hemodialysis already.
Many people are older and older these days. I think it's same in the United States too. And then older people, not necessarily be on dialysis, older people tend to have such a joint and bone disease, especially carpal tunnel syndrome. And like DSA, the spine lesion, that is also like compression fractures and also some nerve neuropathy or those things. And dialysis doctors tend to refer these patients to those orthopedicians and not treated by dialysis doctors. And then I think the symptom of DRA mimic those age-related pain. But if a patient on longer dialysis, physician should suspect the cause of these joint disease and bone disease may be caused by DRA. So I think that's the start of diagnosis.
And just to clarify for the viewers, when you refer to DSA, you refer to destructive spondyloarthropathy.
Yes.
And Glenn, I might turn this around to you a little bit as one of the world leading authorities on metabolic bone disease. How would you suggest differentiating between renal osteodystrophy and DRA in patients complaining of bone pain?
Well, I don't want to veer the discussion away from DRA, but there are so many different causes of renal osteodystrophy as we describe that term, whether secondary hyperparathyroidism or a variety of others. But I think, as our colleagues have said, it's imaging studies that really show a difference. and the bone cysts that we see with amyloidosis
Yes.
are really key. Don't you agree, James?
Yes, I do.
And why do you think DRA is more common in older as opposed to younger patients on dialysis for longer periods of time?
I don't have the idea for the exact reason, but Dr. Tsukamoto also says that getting older, the other spinal disorders happened. So after that, with a longer diet treatment, DSA or carpal tunnel syndrome is happened with severe symptoms in the longer dialysis treatment patient. Just my opinion.
Why is it that DRA manifests in osteoarticular tissues and why not elsewhere?
Extracellular matrix in the cartilage tissues accelerates the amyloid depositions. So extracellular matrix contains collagen, proteoglycans, and glycosaminoglycans. So it's stabilizes amyloid fibers and accelerates the amyloid fiber formation in our experimental system. So I believe that beta-2M monomers or amyloid fibers affinity with cartilage tissues. But recent autopsy studies suggest not only the osteoarticular deposition, but the multiple organ deposition has happened in the longer dialysis patient, including the heart or intestine. So I think not only osteoarticular region, but also multiple organ has amyloid deposition.
I agree with Suguru. We can find amyloid deposition in many organs in DRA, but still osteoarticular symptom is overwhelming, predominant. I think there's a major difference is inflammation, because in synovial tissues with DRA, we can find many inflammatory cells infiltrations. That's a major difference from A-beta-2M amyloidosis with beta-2 microglobulin variants. I mean, the A-beta-2M amyloidosis without uremia. That's a major difference.
In that way, we think that there's more inflammation in patients receiving hemodialysis as compared to peritoneal dialysis. Do you find a difference in the occurrence of DRA in those two populations?
Well, because DRA occurs patient more under dialysis more than 15 years now, so I seldom see the peritoneal dialysis patients over 15 years old.
A paper reported there's no difference of the frequency of the DRA between the peritoneal dialysis and hemodialysis. But those patients underwent dialysis treatment less than 10 years. So I think it's not enough to suggest which is better or worse.
In the United States, we have very few patients on peritoneal dialysis for more than 10 or 15 years.
Yeah.
And you've all pointed out the fact that DRA is more common in persons who've been on dialysis for many years, whether in the US, Japan, or elsewhere. Are there any ways that you've learned or through your research or your clinical practice that we can delay the onset of DRA?
Yes, the improvement of the removal of beta-2M is one of the therapeutic strategies to prevent the DRA. So use a high flux membrane for the hemodialysis or hemodiafiltration may help to prevent the DRA. So after onset of DRA, we can use beta-2 microglobulin adsorption columns for the patient with DRA. It will reduce the serum level of beta-2M and also improve the patient's symptoms, joint pains, or some carpal tunnel syndrome. I think the blood friction treatment is important therapy to prevent or treat the DRA?
I think for prevention, in Japan, most of dialysis facility measures serum beta 2 microglobulin. Maybe not every month, but every 3 months or something. And if it more than 30, I forgot the unit, milligram, microgram milligram per. Okay. If so, we try to improve dialysis. Maybe sometimes use a bigger column or longer dialysis time, and maybe something wrong with patient themselves because of some chronic inflammation or those things. So I think that effective to prevent measuring beta 2M is effective to prevent DRA.
In the US, I think there are financial reasons why longer in-center dialysis treatments are difficult to do. But since 2019, there's been a major effort towards getting patients to treat at home, and home hemodialysis may provide an option for longer and more frequent dialysis treatment. It's too soon yet to see whether that will impact diagnosis of DRA, but it's certainly one consideration.
Also, may I back to the difference between the hemodialysis and peritoneal dialysis?
Please.
In the presentation by Dr. Yamamoto, that you showed that the heparin may stimulate beta 2M fibril accumulation. Is that true?
Yes, this is a basic research to assess the association between glucosaminoglycans and amyloid fibril formation. And heparin is one of the glucosaminoglycans. So I want to emphasize the importance of glucosaminoglycans in the joint, not for the heparin as an anticoagulant. We need the heparin for the treatment of hemodialysis treatment. So it may enhance the amyloid fibril formation using the heparin, but we still need to heparin to treat the patient with hemodialysis treatment.
And in Japan, are you largely using conventional hemodialysis, or are you using hemodiafiltration? As Dr. Silberzweig mentioned, in the US, virtually all patients are on conventional hemodialysis, just diffusive clearance.
We use both. Actually, the percentage of hemodiafiltration is now about 30%. 70% is hemodialysis, but using a high flux membrane. And we can get a better incentive out of that, so we use a high flux membrane.
And I was curious, for those of you who've actively treated DRA, how do you assess response to treatment? For instance, the change in patients' symptoms, signs, or quality of life? Actually,
we cannot find the change of symptoms with hemodialysis or hemodiafiltration is changing the treatment method, but beta 2 microglobulin absorption columns improve the joint pain or some of the improve the muscle weakness. So I think beta 2 microglobulin absorption column will be effective for the DRA.
And to that end, as we were talking about before with heparin, when you use the beta 2 microglobulin absorption columns, you're using more heparin, so that would counteract that argument. And in addition, I wouldn't expect it to affect inflammation.
Yes, well, that's very great point. So we have to think about the amount of heparin or improvement of removal of beta 2 microglobulin. But the result of in Japanese clinical trials, actually the symptom is dramatically improved with the beta 2M absorption columns. So I believe that the use of this column is very beneficial for the dialysis patient with DRA.
And Dr. Kazama, how have you assessed the response to the absorption columns?
Could I answer before this your question?
Absolutely. Please do. Please do.
I like to talk about how to prevent the DRA. So, in Japan, the time from the hemodialysis induction to first occurrence of carpal tunnel syndrome is getting longer and longer in these days. From the 1980s, but in this century, in 21st century, the period is stable after that. And in 21st century, the percentage of hemodiafiltration is getting more and more. So I think the most important, the largest impact is to use non-Q profile membrane, high flux membrane for dialysis. That's the major cause of decreasing DRA, I believe.
And the symptoms?
Yep, probably.
No, that's, I think, usually not the DSA, but the carpal tunnel syndrome we facing for treatment. So we assess the effectiveness by just a reduction of pain, and then also some improvement of motor functions. But very interesting paper, case report said that even after a decade of transplant, that did not diminish amyloid.
Sure.
But instantly the pain and other symptom disappears after transplantation, and maybe because of using steroid for this one. So I don't think it's possible to remove all the amyloid by any type of treatment. But now we only have pain score to assess the effectiveness of treatment.
So if we have now a therapeutic strategy like a beta-2 microglobulin removal column, is there a population of patients that any of you would want to screen for DRA? Because of the point that you raise, if you can't remove the lesions, maybe it's important to act before those lesions cause destructive arthropathy. And are you in Japan screening patients, for instance, who've been on dialysis for 15 years?
I don't think we screen those symptoms. Actually, just depend on the patient complaint and patient symptoms, but we don't do screen.
To my mind, I would think of screening kind of in two buckets. The first would be those patients who've been on dialysis for 10 years or longer, who, as we've all talked about, have a much higher incidence of DRA. The second would be those patients with symptoms suggestive of DRA, so carpal tunnel syndrome or the spine lesions that we've discussed.
Well, you probably haven't seen a really obscure paper of ours from 1995, so more than 25 years ago, that we developed a questionnaire, a screening questionnaire for DRA, which we never applied broadly to the population. But then again, as we know, sadly, we don't have that many patients who survive for 15 years on dialysis. And we do have a sizable number of patients who do get transplanted, where we've found that the symptoms of DRA at least attenuate, or they don't get much worse.
But you used your score for a DOP study in 2009. So
I didn't use it.
you didn't.
Someone else used it. Yeah.
Created by you, and then that said, still, not only in Japan but also in the European country, considerable percentage of DRA, but mainly CTS and the carpal tunnel syndrome.
In terms of screening, I would think that you might begin by using something like your DRA questionnaire as a clinical tool, and then proceed to measuring levels of beta-2 microglobulin, perhaps imaging. Ultimately, the diagnosis certainly can be confirmed by biopsy, but obviously you don't want to do an invasive test until you have strong non-invasive evidence of the disease.
Actually in Japan, to use Lixel beta-2 microglobulin absorption column, that we have, I think, we need 4 conditions to use that. One is a proof of amyloid by surgery or biopsy. And the other one is a bone cyst. Usually it happens on what's the name of this bone? Anyway, hand bone. And then 3, what was that? Anyway, those 2 are mandate to use those columns. So otherwise, we cannot prove the presence of DRA non-invasively.
Has that been your practice, Dr. Kazama?
Yeah, as Dr. Tsukamoto said, only patient with evidence of amyloid deposition histological proven are allowed to use beta microglobulin adsorption column in Japan. So, because the adsorption column is effective in joint pain in those patients, but we don't know whether the column is effective in patients without DRA. We don't have idea. It's important, I think.
Has anybody looked at shoulder ultrasound? And I recall asking patients to see if they could raise their arms above their head, and they have thickening of the rotator cuff. Have you seen that, or is anybody doing ultrasound imaging of the shoulders?
I've seen that, but not by many. Some orthopedicians interested in using ultrasound. Also, you can use for carpal tunnel syndrome too. It's easy to find the accumulation of beta-2M actually, because no other accumulation can be suspected. So if there is accumulation by ultrasound, and this is high possibility of a DRA.
So before we end, maybe I could just ask all of you to just share with me what you think are the next steps we could take to tackle this condition. Maybe why don't you start, Dr. Kazama?
It's a difficult question. Go ahead, Suguru.
I want to emphasize that the medical staff, not only medical doctor, but also nurse as well as patient, should understand and consider the presence of DRA when the patient has a joint pain with a longer diet treatment. So if we have an idea of the DRA, we can use some of the diet changes the diet treatment. So I think every medical staff should share and understand the presence or importance of DRA.
And I think I would expand on that and say that I think the first step is raising awareness and raising index of suspicion among nephrologists, and particularly in the U.S. I think with the recent publication, I believe it was in the New England Journal, about the benefits of hemodiafiltration, I'm hopeful that that will become more widespread and potentially be a preventative measure, as we've talked about. And then finally, in the U.S., the beta-2 microglobulin absorption column has been approved by the FDA under a humanitarian use device exemption, and we're currently conducting a clinical trial with it, so that if there are patients, we can make it available.
The histological examination of beta amyloid is required for the trial?
It is, yes.
It is. This year, I encountered patient with DRA who has only 14 years of dialysis vintage. She is she suffered from severe atrial valve stenosis. So in dialysis session, she has only limited blood velocity, but so we cannot offer the sufficient hemodialysis amounts. I think that's a major risk factor for dialysis-related amyloidosis in recent years. We need sufficient quality and quantity of hemodialysis to prevent DRA. We don't have to do any special therapy. Just we need sufficient quantity and quality of hemodialysis is so important, I believe.
Maybe a patient like that who has great difficulty with ultrafiltration would be a good candidate, for instance, to do, at least in the United States, perhaps to do dialysis at home and do more frequent hemodialysis so that
That's good.
the ultrafiltration goal would be more modest on a 4 or 5 times a week schedule than a 3 times a week schedule. Assuming that you have a patient who is receiving really excellent hemodialysis or hemodiafiltration, whether 3 times a week or 4 or even 5 times a week, and they continue to have symptoms, at what point would you introduce the beta-2 microglobulin absorption column?
Yes, actually, the patient has symptom for the DRA is a time to do the additional treatment like beta-2 microglobulin absorption column. So, but Dr. Tsukamoto already said that we need to show the diagnosis with amyloid deposition with a biopsy, and also needs a history of the Kappa-Tunnel syndrome operations, surgery. So I think next step is to do the definite diagnosis for the DRA, and then we can do the next step for the treatment for the DRA, I think.
Unfortunately, even in Japan, we cannot use that absorption column before patients suffered from CTS or other symptoms. And we really think we need to use that before that phase, before getting much worse. That is for patients. But still, it's also some expensive column in Japan too, and then so we can use that. But ideally, yes, we should use that before they get CTS, if we can find amyloid deposition somewhere in the body.
I wonder if I might ask a question simply because hemodiafiltration is not available in the United States. When do you consider switching a patient from standard hemodialysis to hemodiafiltration? Is it for indications related to beta-2 microglobulin or other indications?
No, usually depends on the patient symptoms, like fluctuation of blood pressure during dialysis, or unexplained lassitude, general fatigue, or like the pain. It's not the local pain, but the full body pain, or those that cannot be explained by uremic symptoms. And then of course after hemodialysis for quite some time, but if patient manifest those symptoms, we change to a hemodiafiltration. but there is not strong evidence for a difference.
Well, hemodiafiltration is so common in Japan. Now, actually, we don't need any special reason to start now. So, Dr. Tsukamoto explained many symptoms that could be relieved by hemodiafiltration, but we start hemodiafiltration before the symptom occurs.
KDIGO had a controversy conference on patient symptoms last year, and now we have a report for this one. That was the main subject: how to find and how to increase the awareness of doctors and medical staff to find the patient symptoms and listen to a patient's symptom. That are the 4 key issues for that controversy conference. So DRA is part of the cause of pain and the other symptoms. So we need to try everything to remove patient symptoms, especially the pain. It's one of the symptom cluster. So I think that was the very important message from that conference.
Beta microglobin adsorption calm does relieve joint pain in patients with DRA, but one thing we can't understand is removing beta microglobin through hemodiafiltration may not relieve joint pains. I don't know why. But hemodiafiltration starts before those symptoms occurs. But we never use beta microglobin adsorption calm before the symptom occurs. Dr. Tsukamoto said, ideally we should start beta microglobin adsorption curves before, but we actually have no data if that's the column has a preventive effect. It's just a relieving effect, but we don't have any idea about it. It could prevent or something.
So, as I see it, what I've heard from all of you is that we have to maintain a high index of suspicion for the condition, maybe screen by searching for the symptoms of carpal tunnel syndrome, which are very troublesome for patients, or other symptoms, and absolutely concentrate, as you've pointed out, on the quality and thoroughness of the dialysis treatment, and then at some point, depending on the results of your clinical trial, maybe consider the addition of the absorption column. But I've really enjoyed our discussion. Any closing comments from you all?
I'd just like to thank you and to thank KDIGO for the opportunity to have this discussion. I think it's a very important and very valuable discussion, and I appreciate having the opportunity to speak with all of your expertise.
Thank you for excellent discussion.
Thank you for joining us. It was a pleasure. I'd like to thank each of our presenters, and I'd like to thank those of you watching. Please share this resource with your colleagues, and keep on cheering for KDIGO. Thanks.